of mimickers that we have for vasculitis, as well as once we have diagnosed, then there are a lot of subtypes which we have to distinguish between. So we will go to a stepwise approach, a very systematic approach that I hope the residents will find it useful and would be able to implement it in their practice. So basically, it is a broad group, as I already outlined, and there's the basic pathology which is common to all of them is that there is inflammation and damage to the dermal blood vessels. Here we are talking about the skin. So of course, it is dermis and in some cases subcutaneous tissue also. But the large majority of vasculitis that we come across, most of us, are basically dermal vasculitis, and few of them are even in the subcutaneous tissue. So the lesions that we see can fall into either of these three categories. That is, first, it could be a cutaneous manifestation of a systemic vasculitis. So basically, as we will go across in the lecture, we will see that what systemic vasculitis can have cutaneous presentations. So one of them is granulomatosis with polyangiitis, which was earlier known as Wegener's granulomatosis. The second component of cutaneous lesions would be when it is skin limited. So that it means that it is a systemic vasculitis, but usually it is limited to the skin mostly. So that comes in cutaneous polyarthritis nodosa. And the third is basically a single organ vasculitis without a systemic component. So that is basically typically seen in ED or erythema elevatum diutinum. Now, as we have seen that these are very wide entities and very different entities, so a stepwise approach is definitely required to basically manage them, first diagnose and manage them. So as you see a case of vasculitis, the first thing that should come into your mind, like if you think, is the morphology. So when the patient presents to you with cutaneous lesions, as we are a dermatologist, we are very fortunate that we can easily examine these lesions and the skin is easily accessible to even biopsy and can basically be the first presentation in many of these systemic vasculitis. So first we have to see whether it is basically a vasculitis or is it a mimicker of vasculitis, which is also called as pseudovasculitis. We will come to that in the subsequent slides also. This is just an overview. And once we see that this is a vasculitis or we are suspecting that it is a vasculitis, we have to know that whether there is a cause for this. Are there any systemic disease associations to it? Is the patient having any other systemic disease which can be associated with this kind of presentation? Or there are other organs which may be affected with similar pattern of involvement like vasculitis in extracutaneous sites. So after this, we should know that what are the basic terms. So we come across we have skin terminologies for almost all types of skin lesions. And as a first year resident, I know every one of you must be knowing what are the primary skin lesions, what are the secondary skin lesions. And we do come across these type of lesions in our terminologies. That is, what is a purpura, what is a petechiae, and what is an echinosis. So this is relevant because we will be using a purpura as a very common term in the subsequent slides. So you should know what is purpura. Purpura basically refers to a discoloration of the skin or the mucosa. It can occur even in the mucosa due to extravasation of the red blood cells. So this is basically when there is a damage to the blood vessel and there is RBC extravasation, which causes a discoloration onto the skin. That is called as purpura. Now, there are other two entities which are also commonly used, which is petechiae, and that is very small, 1 to 2 millimeter purpuric lesion. So it is again a discoloration, but it is very small, that is less than 1 or 2 millimeters. And echinosis, on the other hand, again, because of the size, they are basically more than 1 centimeters in size, and again, due to the extravasation of the blood. So these are the terms that we commonly use. We will be restricting ourselves to purpura. Of course, we know petechiae when they are because of thrombocytopenia and other causes, and echinosis also when there are larger areas involved, like more than 1 centimeter. Now, when we say that purpura, again, as dermatology, we have so many terminologies and so many nomenclatures. So we have different types of purpura as well. So we have to be very particular as to what kind of purpura we would be considering or dealing with in our subsequent slides. Now, these are basically of 3 types. This could be either a macular purpura, which is non-retiform macular purpura. Now, this is often seen in platelet coagulation disorders due to thrombocytopenia and other coagulation diseases, which normally do not come to us. They are often seen with hematologists. Then we come across the inflammatory palpable purpura. Now, this is something which is the hallmark of cutaneous vasculitis. So there is inflammation, there is damage to the blood vessel, and that is basically causing a lesion which is raised. That is why it is called a palpable purpura and not macular or just a discoloration. And then we have non-inflammatory or retiform purpura, which is very characteristic of thrombo-occlusive disorders, maybe emboli, cholesterol emboli, or sometimes even livedoid vasculopathy or Apla syndrome. So these are actually the mimickers of vasculitis, and because they have different types of lesions, we have to differentiate these lesions from the typical lesions of vasculitis. And sometimes vasculitis can have these lesions also, but then there are other features which will help us distinguish them. So this is the classification of vasculitis. As we all must be aware, there have been some changes to this as from the previous classification that was proposed long back in 1994. Now this was proposed in 2012, and there are some, basically this is the broad classification that I would um, enumerate here, that we have small vessel vasculitis based on the caliber of the vessel which is involved. It can be, I will be just showing it in the subsequent slide. It can be either small vessel, it can be medium vessel, it can be large vessel. Then it is either variable vessel. Variable vessel is when there is no particular size involved. It can involve either small, medium, or large vessel. And then there is a single organ vasculitis, which we commonly see, and that is the cutaneous leukocytoclastic angiitis or vasculitis. Now, coming on to the small vessel vasculitis, these are also seen not infrequently. Some of these are seen and referred by our rheumatology colleagues also. And these are the ones which can be either immune complex associated or ANCA associated. So immune complex associated vasculitis, the commonest one which we see is the IgA vasculitis, which was earlier known as the Enoch-Schonlein purpura. Now, this is the commonest vasculitis that you see in children, and also sometimes we see in adults as well. Then we have hypocomplementemic urticarial vasculitis, which is characterized by the urticarial lesions predominantly. And the third one is the cryoglobinemic vasculitis, which may not be very frequently seen. The small vessel vasculitis can also be ANCA associated when it is microscopic cholangitis, Wegener's syndrome, based on the ANCA which is involved, that we will come across in the subsequent slides, and Churg-Strauss or the eosinophilic granulomatosis with cholangitis. So these are the new names for the entities which were earlier called as Churg-Strauss and Wegener's granulomatosis. The medium vessel vasculitis, classically it is of two types, the cutaneous pan that again we see, and Kawasaki disease, which sometimes we do get referrals for this also from pediatrics. And then we have the large vessel involvement, which are not usually seen by us. That is the giant cell arthritis or the temporal arthritis and the Takayasu arthritis. The variable vessel arthritis is commonly, which we come across, is the Behçet's disease, which has many other features to it, maybe joint pains, abdominal pain, aphthe, and other things, and the Cogan syndrome. And again, the single organ vasculitis that I referred to earlier, which is the commonest leukocytoclastic vasculitis. So this is the actually most common one that we see in our practice. So this was the diagram that I was referring to, that again, based on the vessel involved. So as you can see that this is like the large aorta vessel, which is branching into the medium vessels. And then you have, these are the small arteries. And then these ones are the arterioles, capillaries, and the venules. So when you start from the small vessel vasculitis, I mentioned that it could be either as the immune complex, where you have deposits of immune deposits in the vessel wall, or it could be pauci-immune, that is ANCA associated vasculitis. In pauci-immune, usually the DIF would be negative. So we will be discussing that subsequently. And in immune complex, we already mentioned which are the commonest ones. Out of these, the IgA or the Enoch-Schonlein purpura is the one we commonly see, which has IgA deposits. The ANCA associated are actually having a lot of systemic features to them. Sometimes they are referred to us for biopsy and evaluation. Many of these are actually diagnosed and treated by rheumatologists because they often involve other organs. Then we have the medium vessel vasculitis, of which we see commonly cutaneous pan and Kawasaki disease in some cases. And then we have large vessel, which normally we do not come across, basically are Takayasu arthritis and giant cell arthritis. So this is just to show how the disease basically classified based on the size, diameter, or caliber of the vessel. Now, then there are some other secondary vasculitis or vasculitides, which may be associated with systemic disease, because in the approach, we mentioned that there could be vasculitis associated with some systemic associations. So a patient could have a lupus, erythematosus, and he could have coexisting and simultaneously involvement with the vasculitis on his lower limbs. They could be patient with rheumatoid arthritis, sarcoidosis, which can have cutaneous vasculitis. Then vasculitis associated with probable etiology. We will come to that subsequently also. So this is the Chapel Hill classification that has been given and it was modified. So these are the newer entities that have been put in the classification. So coming on to the etiology, as we just saw in the previous slide, that is the vasculitis associated with probable etiology, we see that there is hepatitis B, C, drugs, etc. So this is just to enumerate that when you see a suspected vasculitis, you have to see whether there is an underlying etiology to that. But surprisingly, or as you must be aware, that in 50% of the cases, we do not find an etiology. So idiopathic form is the commonest form in adults, at least, while infections, I would say, are the second most common cause. Particularly, sometimes they are very important in children. The infections are an important cause of vasculitis. The other common causes that we come across, which are less often seen but may be associated, like we mentioned, are the CTDs or the connective tissue diseases, other inflammatory conditions, rheumatoid arthritis, etc., drug reactions in a percentage of 10% of cases, and malignancies or lymphoproliferative disorders. So basically, cases which are refractory, they come back again and again. They do not get resolved with our conventional immunosuppressants or immunomodulators. And the patients keep on having recurrent lesions. They should be evaluated for malignancies and associated CTDs. Otherwise, we all know that cutaneous vasculitis is usually a self-limiting condition. So in most cases where there's idiopathic, no etiology found, these are often self-limiting. Now, as we go for the approach, so the basic thing that we all know, which is taught to us in every patient, is how we take a history, and that actually guides you to the investigations or the examination findings that you will get in a given patient. So you cannot just order and write a battery of investigations for vasculitis, as there are so many disorders associated with it. You need to know the positive findings in the history. You need to know the positive findings in the examination, and then you proceed on to the investigations guided by your history and examination. So first come the constitutional symptoms. Now, these are very common. Like we do come across patients who have systemic involvement, or they would have underlying CTDs, and they would come with these features of weight loss, fatigue, fever, myalgia. Now, these are common symptoms in patients who have underlying systemic involvement with vasculitis or any underlying systemic disease in the form of CTD. Joint pain and swelling, again, IgA vasculitis, inox is very characteristic for knee pain. Connective tissue diseases, of course, can have associated joint involvement. Nasal or sinus congestion, epistaxis, rhinorrhea, ear pain. So these are basically the upper respiratory tract symptoms, the oral and the nasal cavity involvement, the sinus involvement. This goes very much in favor of vaginous granulomatosis or granulomatosis with polyangiitis. So if a patient has these ENT complaints to you, he may maybe earlier having these patient complaints and then present with cutaneous lesions, or sometimes cutaneous lesions are the first presentation and these come later on. So that is how you can diagnose clinically. You can actually pinpoint that this could be probably vaginous, and I have to get these investigations done. Then comes the respiratory, the lower respiratory tract symptoms, which could be in the form of cough, dyspnea, hemoptysis, and chest pain. Now, these are because of the involvement of the lungs, which are commonly seen in the urticarial type of vasculitis, the hypocomplimentemic type of urticarial vasculitis. Asthma, allergic rhinitis, maybe the atopic features kind of, if a patient has, then it is very much suggestive of choked straws or eosinophilic granulomatosis with polyangiitis. So among the respiratory complaints also, if you see, you have to be very specific in asking the patients, what do they have? Whether they have upper respiratory involvement, lower respiratory involvement, whether it is just asthma, whether there's dyspnea. So that is important. And there comes the role of a multidisciplinary approach also in these patients, which are those having systemic involvement. Then comes the GI involvement, the nausea, vomiting, pain, abdominal pain, blood in stools, very commonly seen in IgA vasculitis, also in urticarial vasculitis. The neurological symptoms, because you have to now go system-wise. So you have to ask for any numbness and paresthesias in these patients to rule out any cryoglobinemic vasculitis, urticarial vasculitis, because they can be associated with mononeuritis multiplex. Then microscopic polyangiitis. So these are all the types which are associated with neurological complaints. Blood in urine, blood in stools. We all mentioned IgA vasculitis, urticarial vasculitis. Of course, glomerulonephritis is an important feature in many of these vasculitides, especially the cryoglobulinic vasculitis and microscopic cholangitis. To know the etiology, you often ask these patients whether there has been a recent drug intake in the form of, we will go see subsequently which all drugs are common culprits. Is there any photosensitivity, Raynaud's phenomena that is typically seen in patients who have LE and that is associated with hypocomplimentemic urticarial vasculitis? Whether there are other features to suggest CTDs like dry eyes, dry mouth, Sjogren's syndrome can be there. There can be red eyes, ocular involvement, that where there's hypocomplimentic urticarial vasculitis. And you have to know whether it is the first episode or whether these are recurrent episodes. Because as I mentioned, that if a patient has recurrent episodes, it usually suggests that there's some underlying involvement in the form of any CTD or in the form of any malignancy, which we are probably missing, and the patient needs to be investigated. Now, this is the list of drugs. Obviously, it is not a complete list. There can be many drugs, other drugs. Of course, ATT is also one culprit, which we sometimes see causing vasculitis. And then there are a host of other drugs like antibiotics, penicillin group, the sulfonamide group. Then there can be NSAIDs, thiazides, anticonvulsants, allopurinol, anti-TNF alpha agents, and some colony stimulating factors. So think of drugs. There's maybe some alternative medicines which the patient might have taken for some other disease, and that could have actually led to vasculitis. So take a very thorough drug history, because in drugs, if you stop the culprit drug, the disease would actually go, and it is having a good prognosis. So after the basic history that we have taken system-wise and to rule out any underlying etiology and associations, we now go on to the examination. And the general examination is very important in such patients because we need to know whether the patient is stable, what are the vitals of the patient, whether there is any systemic involvement in the form of respiratory rate being high in case of dyspnea in a patient, or a temperature. Patient may be febrile if the patient has underlying LE or other systemic involvement. Then comes the other general physical examination details, whether you have pallor, icterus. Now, icterus is something which is very pointing towards sometimes an association with an underlying etiology, like a patient may be a patient of hepatitis B or C, a diagnosed case, and can present with this. So this is a common scenario which sometimes we get from our medicine colleagues. The patient is Hep C, Hep B positive and has developed these palpable purpura-like lesions. Or sometimes they can have PAN, polyarteritis nodosa, which is commonly associated with hepatitis B. Limb edema, they can be pedal edema. It could be either renal involvement because of the renal involvement in systemic vasculitis, or it could be disease related also because of the inflammation that is occurring in the blood vessels. There could be local pedal edema. Lymphadenopathy in a patient of a vasculitis would again point towards some serious process going on, maybe a malignancy that can be a paraneoplastic manifestation kind of in vasculitis. So after our general physical examination, we go on to the systemic examination. And in the systemic examination, we all know stepwise, if we go, we have to see whether there's a respiratory involvement. We have to take help of our colleagues in internal medicine. If we are suspecting something, we need to refer to these patients to rule out any underlying lung involvement. If there's in the form of any pleural rub, pleural effusion, sometimes SLE, pericardial rub, any crepitations, abdominal pain, tenderness, hepatosplenomegaly, again pointing towards IgA vasculitis, neurological involvement in the form of sensory motor neuropathy, pointing towards microscopic cholangitis and other ANCA-associated vasculitis, and musculoskeletal involvement, joint pain, again points towards CTDs. ENT involvement, as we already mentioned, thorough ENT evaluation should be done in patients who have these symptoms of sinusitis. So based on your history, if you find out that these are the systems where the patient is having a positive history, you will spend more time and go do a detailed examination of that particular system and also refer the patient to a particular department where you think that this can be picked up. So systemic examination, the depth of the vessels we go on to, and then we go on to the cutaneous examination where the depth induce, there can be clinical manifestations depending on the location and the size of the vessels involved. And the depth of the affected vessels is actually correlated with the type of the cutaneous lesions. So we will go on to the cutaneous examination. And we all know that based on what kind of blood vessel is involved, there can be different type of lesions. So once we have done our systemic examination, we will see what the patient has, what kind of lesions the patient has. And then in cutaneous small vessel vasculitis, which we commonly see, or the leukocytoclastic vasculitis, we have the classic palpable purpura. So I will be showing the images subsequently in next slide. While there can be other lesions also, as I mentioned, there can be urticaria lesions, there can be petechiae sometimes, there can be vesicles, hemorrhagic vesicles, and pustules. So many kind of clinical manifestations can occur. So it may not be very easy sometimes. It is not straightforward. But if there is accompanying palpable purpura sometimes to these lesions, then you can actually think of, okay, I'm dealing with probably a vasculitis, or I need to investigate the patient for vasculitis. I need to do a biopsy if the lesions are quite atypical. Now, the common sites that are involved are the lower extremities and areas of pressure. So we all know that the lower extremities are commonly involved. Sometimes the lesions can also occur on areas which have been traumatized. So that is basically a Koebner phenomena which can occur in vasculitis. Now, there can be other manifestations also like subcutaneous nodules. There can be retiform purpura, which we mentioned, necrosis, ulceration. That usually suggests that there is either a medium vessel involvement, or sometimes there can be an overlap of small and medium vessel involvement. There can be palpable purpura along with some ulceration. There can be nodules along with some ulceration and palpable purpura. So this mixed kind of picture is often seen in PAN and ANCA-associated vasculitis because they have an overlap between the small and the medium-sized vessels. So the small-sized vessels, which actually, this is the way to, you can memorize that if a small-sized vessel is involved, the morphology will be purpuric papules, macules, hemorrhagic vesicles, targetoid lesions, edema multiforme-like lesions, and urticaria lesions. While if it is a medium-sized vessel which is involved, it will be mostly a livedo kind of pattern, a net-like pattern, which is livedo racemosa kind of pattern, an infarct, an ulcer, or a nodule, which is deep-seated in the subcutaneous tissue. And sometimes there can be a combination of these features, which I mentioned could be seen in a ANCA-associated vasculitis. So seeing some of the morphologies, you should know that this is palpable purpura, the typical classical lesions on the lower limbs, suggestive of a small vessel vasculitis. And these are, again, you have some palpable purpura in the vicinity, but these are some bullae, hemorrhagic bullae, which have developed in these patients so this is again a suggestive of a small vessel involvement. Hemorrhagic vesicles and bullae can be seen again in a small vessel vasculitis. Then you sometimes have these urticaria lesions, wheel-like lesions, but they would be persisting. They would not go away in 24 hours, unlike urticaria. They would be tender rather than itchy, and they would leave behind post-inflammatory hyperpigmentation. So this is how you classically differentiate urticaria from urticarial vasculitis. Now, these are some of the lesions which we can sometimes come across and which we get referrals sometimes, but not commonly. So these are necrotic ulcers you can see. These are again ulcerations which you see. These are retiform branching kind of purpura which you are seeing, non-blanchable purpuric lesion. And this is something which is digital gangrene or infarct which you see. So this type of features are actually suggestive of a medium vessel involvement, and that could be seen in a ANCA-associated vasculitis. Now, coming on to another kind of involvement, again, so this was one patient which we had seen. The photograph on the left, two are of the same patient. One is involving the face, one is involving the legs. If you see on the legs, these are actual palpable purpura, some are bullae also on the purpuric base. And this is the face of the same patient. So he is basically having purpuric lesions with hemorrhagic bulla. And this is a very atypical morphology. The lesions are quite large and they are involving the face, which is not a common sight. So this was actually a patient of Churg-Strauss. And he was diagnosed case of Churg-Strauss. He had eosinophilia, he had asthma, and he fulfilled the criteria. And he presented with these kind of lesions on the face and the lower limbs. So this was in EGPA. Then sometimes you see EED also, erythema elevatum diutinum. It is also a type of vasculitis, though it is not there in the current nomenclature, but it is a type of fibrosing vasculitis. And we sometimes see these cases when they present with these hard firm nodules on the extensors of the extremities, maybe associated with an underlying malignancy or HIV. Now, as you go for a cutaneous examination, you must know that there are some mimickers, as we mentioned. So you may be confused in the initial stages, whether I'm dealing with a vasculitis or whether I'm dealing with a mimicker of a vasculitis. So what are these mimickers or a pseudovasculitis kind of? And they are often very confusing. It is not very straightforward because patient may not come to you right on day one or when the lesions have started. He may come to you after he has taken treatment or very late in the evolution of the disease when the lesions may not be very representative of vasculitis. So then you have to think if whether I'm dealing with petechiae, purpura, and whether these are related to thrombocytopenia or any platelet function disorders or any coagulation disorders. Now, the picture on the right is actually suggestive of atrophy blanche. So these patients will come to you with painful ulcerations. They will come to you with livedo-like lesions, and they would just heal with such irregular net-like pattern, which is actually atrophy blanche kind of scars with surrounding telangiectasias, commonly around the ankle. So this is actually livedoid vasculopathy, which is an occlusive condition. It is not a vasculitis. It can be distinguished from vasculitis, as I will show you on histopathology, and the treatment, the associations, the etiology are all different. So it is important to differentiate these from vasculitis. Then we have PPD, which are flat purpuric macules, very small in size. Sometimes they may coalesce into plaques that can be seen on the lower limbs. And again, these are not palpable. Now, once we have through with our history, we are through with our examination, we know that we are probably dealing with a vasculitis. We now need to investigate the patient, and our investigations will be based on what positive findings we have got on history and examination. So why do we need to investigate these patients? Why we have to do these tests? First, we have to confirm our diagnosis because as I showed you the images, not all patients would have palpable purpura. They can be very different kind of lesions. And that can actually make you think that, okay, we need to perform a biopsy and rule out vasculitis, rule out other mimics, because you can have vasculopathy also. Then you have to look for evidence of vasculitis in other organs. As we mentioned, that extracutaneous involvement can be there. And then you look for associations because you can have a systemic associations in these patients in the form of any CTD. So you have to investigate whether the patient has CTD, infection, or malignancies. So this is stepwise because we will see in subsequent slides where we have to order which investigation. Not all investigations are required in every case of vasculitis. So this is a basic overview of the diagnostic workup. When do you want to do? We have a whole battery of tests or an extensive workup for these patients. And we have a limited workup or the basic investigations that we do. So what patients you will do a basic investigation workup? First of all, we have to know whether there is a clear etiology. Now, sometimes patient says that I took this drug and I got these lesions, maybe within a week or within a few days of taking this drug. So there's a clear inciting factor. There is single episode, no previous episode, no internal organ involvement, no associated systemic disease in the form of history that you have asked to this patient for CTD or something which is negative, no forthcoming positive history. Then you will do a limited workup, which we will tell subsequently. I'll discuss what is a limited workup in these patients. But if a patient has unclear cause, you're not able to pinpoint what is the cause, or patient is having multiple episodes. He has come to you maybe 4 to 5 times, very recurrent disease, and history and examination are forthcoming with some internal organ involvement. Or he has some systemic association in the form of some joint pain, Raynaud's, or photosensitivity. So then you will order a extensive workup for these patients because recurrent cases I already discussed or told that would have an underlying cause in majority of these cases. The cause may not be evident to you, you have to search for it. So this is the limited workup that we will have to see for a patient who has vasculitis, which is single episode and etiology known, drug history or some history which the patient gives, no systemic history, no systemic involvement. You just go for a biopsy and a DIF to confirm your diagnosis. You do a CBC, a differential count, and a peripheral count. Maybe you get a raised TLC for infection-associated vasculitis or an eosinophilia, which is more than 10% for Church-Strauss. That will help you in your diagnosis. You get an ESR and CRP done. That will be raised in a case of systemic vasculitis or an infection-induced vasculitis. A renal function test is an important workup because many of these vasculitis, including IgA vasculitis in adults, can have renal involvement. in the form of hematuria, proteinuria, and red cell cast also. And then you do a basic liver function test, because these are the basic tests we do for many of these patients: LFTs, RFTs, ESR, CBC, and a biopsy. So this is the limited workup you will write for a patient of vasculitis who has a single episode with a given etiology. Now, what is the extensive workup? So as you see, the list is quite exhaustive. It is having a lot of investigations and it may not be complete. And I have listed most of the investigations, but there may be some still investigations which are left out. But these are the important ones that you will order in a case which has recurrent episodes and has some positive systemic history. Depending on what you are thinking, you will order these investigations. So we have IgA vasculitis, an underlying streptococcal infection. You will go for a ASO or throat swab. A MON2 test is always done in these patients because tuberculosis is endemic in our country, and we have seen many patients who have associated tuberculosis, or sometimes they have ATT-induced vasculitis also. We do a hepatitis B, C serology again to rule out a cryoglobinemic vasculitis when a patient has manifestations of vasculitis which is coming up only at cold temperatures during winters, and that we suspect due to a cryoglobinemic vasculitis. An HIV for EED and other vasculitides. ANA is important because if you're thinking of SLE, then you have to go for ANA in hypocomplementemic vasculitis. A rheumatoid factor for cryoglobinemic vasculitis, complement levels again for a hypocomplementemic vasculitis. ANCA levels, again, as I told you, C ANCA for GPA or the vaginous granulomatosis, P ANCA for eosinophilic and MPA, that is microscopic cholangitis. Then you have ANCA-associated drug vasculitis, where you have to do many drugs like levamisole and other drugs can cause ANCA positivity. Once you have basic urine workup, you have to do this 24-hour urine protein and creatinine clearance also if you are thinking that there is a renal involvement. So you go for further tests in these patients, you go for urine albumin creatinine ratio also, and then consult your nephrology colleagues. Cryoglobulins levels should be done. Stool for occult blood should be done if you are suspecting a malignancy or a IgA vasculitis or an associated inflammatory bowel disease. Serum protein electrophoresis, again, for patients who have an hypocomplementemic vasculitis, or sometimes even if you have a suspected myeloproliferative disorders or sometimes myeloma, then these should be ordered. A chest radiograph and followed by a CT chest when you have ANCA vasculitis, because they can cause lung involvement, they can be lung hemorrhage, they can be parenchymal involvement, and those can be picked up by using these chest X-ray and CT chest. Then malignancy markers for patients who are elderly, normally you do not get these manifestations in elderly patients. It is usually young females or males who get, or children. But if you have an adult who is giving a vasculitis, this should raise an alarm that probably it could be a paraneoplastic manifestation of an underlying malignancy. Or you have to see malignancy markers depending upon the clinical scenario, like which malignancy you are suspecting. Based on that, you can order these investigations. And for those who have neurological involvement in the form of mononeuritis multiplex or sensory motor neuropathy, particularly that are seen in cryoglobinemic vasculitis, you go for nerve conduction studies. So as you see that this is a very big list and this may not be complete. There are many other investigations which may be there. Once you get something positive, you have to order for further tests. This is how you go further. Now, the most important part of that we can do in these patients is something which is skin biopsy. Now, skin lesions are very accessible to biopsy, and sometimes they can be they can actually give a clue to the diagnosis. So we should go for a skin biopsy in these patients. And what is the prerequisite for a skin biopsy? That the lesion should be fresh. It should be less than 24 to 48 hours old and a well-established lesion. So sometimes it may be just like the patient may say that it has just come yesterday or may not be even 1 day old, that it may not be well established, or it may not be that erythematous. So you have to take a well established erythematous active lesion, preferably above the knee, because of gravity, you have a lot of features which you do not want in a biopsy because of the venous hypertension. These blood vessels may be very thickened. So you actually take a lesion which is above the knee level. And also it is good for healing because the lower limb, if you take below knee, it may be not good in healing. A punch biopsy is sufficient. A 4 mm punch would be just ideal. Or Sometimes you have to take a nodule or a purpura if you have a medium vessel vasculitis. Then you take a elliptical biopsy, because in that case you will need a incisional elliptical biopsy. A punch may not be sufficient to get a biopsy which is in the subcutaneous tissue, like a pan or an erythema induratum, which have subcutaneous nodules. The biopsy should be incisional. So, what is the role of skin biopsy? Do we need to do it in every case? I would say no. Unless it is for some academic purpose, you need not do in every case. You need to do in cases where you have atypical lesions which are not palpable purpura, or they are mimicking vasculitis, or you are thinking of some other alternative diagnosis in those cases. Also, sometimes you need to know whether it is a small vessel vasculitis or a medium vessel, because there can be some overlap of lesions and the treatment may be little different in some of these vasculitis. So it can tell you that it is a small vessel or medium vessel, though that you can judge based on the type of lesion also if you have a nodule. So it is just an additional finding that you will get, because biopsy would actually give you the caliber of the vessel. And then what is the infiltrate that you have, whether they are eosinophils in choke straws or whether they are neutrophils in a common leukocytoplastic vasculitis. So this is a biopsy of a well-established lesion. You can see that the epidermis is essentially normal. There can be sometimes a bulla or a necrosis of the epidermis, depending on what kind of lesion you are biopsying. And there is some edema in the dermis. You see some papillary dermal edema is there. And the rest of the dermis looks very busy, and there is a lot of infiltrate around these areas, mid dermis, upper dermis. The whole dermis is actually involved. So when you zoom into these areas, because you see some pink areas, which is actually this pink fibrinoid necrosis that you can see, which was there in the small low par as well. So this is what is the high par of this area. You see that this is something very concentrically oriented. So this is suggestive of that it is surrounding a vessel. That is one clue, because something around the vessel would appear as like concentric arrangement. And there's lot of neutrophils that can be seen, these small nuclei, the dust, nuclear dust can be seen all around. If you see, along with obviously lymphocytes are also there. But the key cells here should be the neutrophilic infiltrate or the neutrophilic debris. Some of them are even invading the wall. Then the fibrinoid necrosis, that is the pink material which has replaced the vessel wall. And there is some RBCs which can be seen here in the vessel lumen. Sometimes they are present outside the vessel, like you can see here outside the vessel. So this is RBC extravasation. Okay. And if you see that these are the endothelial cells. So these endothelial cells which are lining the vessel are quite plump or swollen. This is because that this is damage to the vessel. So they are no longer flat. They are actually swollen or plump in shape. So these are some of the hallmark features of vasculitis. There will be neutrophilic infiltration of the vessel walls with nuclear debris or dust, which we say, that is called as leukocytoclasia. Then there can be fibrinoid necrosis and disruption of the vessel wall. There can be endothelial cell swelling and extravasated erythrocytes. Now, these are the four cardinal features in histopathology of a small vessel vasculitis. But mind it, these changes are not seen in every case. You may see two features, you may not see two features, depending on the timing of the biopsy. Now, fibrinoid necrosis occurs a little late. It may not be there in a very early lesion, but neutrophils will be there, endothelial cell swelling will be there. And sometimes if you biopsy a very late lesion, then the neutrophils will disappear and they will be replaced by lymphocytes. So then the diagnosis becomes tricky in those scenarios. You have to correlate it with your clinical findings. So what are the soft pointers? I told you that the infiltrate can tell you something, the caliber can tell you something if you do a biopsy. It is not just that the clinical picture is sufficient. So sometimes you have involvement of both the small and the medium-sized vessels. Then you have to think that probably I'm dealing with an ANCA or a connective tissue disease associated vasculitis. Sometimes you have neutrophilic infiltrate, which is interstitial also besides the vessel wall. Then you have to think of urticarial vasculitis. When there is eosinophilia, you should think of whether I'm dealing with a drug-induced vasculitis or whether there is a chute straws or EGPA kind of vasculitis, because they have peripheral eosinophilia, they have tissue eosinophilia as well. And sometimes you may find, if you're lucky, then you may actually see granulomas in your vasculitis. That is a feature of Wegener's and Church-Strauss, that is granulomatosis polyangiitis and eosinophilic granulomatosis with polyangiitis. Extravascular granulomas may be seen in these cases, but they are less common. They are not seen in all patients. Now, this is something that I wanted to show because we do see a lot of livedoid vasculopathy cases, and this picture I had shown earlier also in mimickers or in DDs. That when you are seeing, sometimes these patients come to us and we think whether we are dealing with vasculitis, they may be having some livedo-like lesions in the initial stages, very painful ulcers also around the ankle. But when you biopsy this lesion, you will see this thing. What does this show? So there is a lot of RBC extravasation. There is fibrinoid necrosis. You can see there is a lot of pink material around the vessel wall. And actually, there is occlusion of the vessel. There is a lot of thrombi which are present in these vessels. The pink material inside the lumen is actually the thrombus. There is a lot of RBC extravasation. But what is missing here, which is very strikingly seen, there is no neutrophilia or there is no neutrophilic dust which is present. So this is the feature which differentiates the vasculitis, leukocytoplastic vasculitis, from vasculopathy. Because vasculitis means itis is always referring to inflammation, that is the neutrophils. Whereas vasculopathy usually has lymphocytes and not neutrophils. Lymphocytes are also very sparse, but the other features would actually mimic that of vasculitis. There will be fibrinoid necrosis and extravasation of erythrocytes, and there will be thrombi in the lumen. So this is important to differentiate vasculopathy from vasculitis. Now, coming on to the DIF, which we do in many of the cases, DIF is important because, first of all, DIF can help you, as I will enumerate, but it has to be taken from, again, a very recent lesion because otherwise the immune reactants will get destroyed. So it should be, again, within 24 hours, a lesion should be taken and it's lesional. Unlike immunobullous diseases, where you take a perilesional DIF, this is from a lesion and not perilesional. So you see a lot of IgA deposits, then you have to think of IgA vasculitis. And those patients who have IgA deposits, they have sometimes associated with a high risk of renal involvement, particularly in adults. Sometimes you see prominent IgM deposits, then you have to think of cryoglobulinic vasculitis or rheumatoid arthritis associated vasculitis. Because rheumatoid factor, if you know, is IgM. Sometimes you see multiple immune deposits. So you have more than one deposits and they are present in the blood vessels and they are present even in the basement membrane zone. Then you have to think whether I'm dealing with urticarial vasculitis, the hypocomplementemic type, which is often associated with SLE. So there you have multiple immune deposits and at more than one place, that is in the blood vessels as well as the basement membrane zone. A negative DIF can be seen in many of these vasculitides, specifically the ANCA-associated vasculitis. So this is the IgM in the blood vessels. So obviously, the deposit will not tell you it is IgM. It is the antibody that you use actually tells you the IgM, where it can be seen in cryoglobulinic or rheumatoid factor. These are the blood vessels and they are quite highlighted. They show this immunofluorescence positivity. And this is IgA positivity in the blood vessels. Of course, you need a good pathologist to interpret these findings and a good biopsy, which should be a recent from a recent lesion. Now, this is a big flow chart. I will just go quickly, and we have already discussed the algorithm, how to approach the vasculitis. So, if you are dealing with a morphology which is suggestive of palpable purpura, in most of the scenarios, it will be palpable purpura, but you do get atypical lesions also. Then go for histopathology and DIF. Look for the histopathology features that I have mentioned, whether they are eosinophils, whether there is a medium and small vessel involvement, whether there are any granulomas or eosinophils or neutrophils. So look for the infiltrate, look for the caliber of the vessel that is involved. What is the DIF deposit, whether it is IgA, IgM, or whether it is negative, then it is suggestive of ANCA-associated vasculitis. In case you are not dealing with a palpable purpura, you know, okay, this is probably not vasculitis, so you will think of alternative diagnosis. And maybe those diagnoses would be clarified on biopsy also. You may not have to do biopsy in many of these cases, or sometimes you may have to do biopsy in these cases where you have PPD, thrombocytopenic purpura, and other causes. Then once you are dealing with a vasculitis, you need to know whether there's a systemic involvement. So you need to take a proper appropriate history of all the systems, constitutional symptoms, musculoskeletal, renal, gastro, neurologic, cardiopulmonary, and ENT. So these are the common systems. So a review of all systems should be done in both history and examination. Then if you have these systemic involvement, you evaluate extensively, as I mentioned, and refer to your colleagues in different departments. If you do not have these and you think that this is the first episode, probably you are dealing with a limited skin limited vasculitis, and then you just go for a limited workup, which is just a CBC, a KFT, a ESR, and LFT with urine analysis. If you think that you have a clear inciting factors for vasculitis, a clear etiology, as in a drug-associated vasculitis, you go for, again, a limited workup. If you think, no, probably there are some other causes, internal associations, or a malignancy, or any other cause, then you go for an extensive evaluation. This is again an exhaustive chart of the same disorder-wise, what lesions you see, what kind of deposits you get, and what is the tentative diagnosis. So there can be a lot of like many conditions which are there. You have to take everything in totality, whether we are dealing, what are the cutaneous lesions, what are the histopathology findings, what are the other lab findings, what is the DAF of the patient, and then actually come to a concluding diagnosis. So I think this is my final slide. I will conclude here, and thank you very much for your patient listening.